I think, one of the biggest challenges is that, we have these kind of theories about how our programs work, but we have not tested those theories. So we can't say for sure, what matters the most. So until we have that information, we really don't know.
On episode 6 of the Prevention Matters podcast, I chat with Dr. Cady Berkel from Arizona State University. Cady's work focuses on examining how community-based mental health and substance use programs are implemented and how this affects the effectiveness of prevention programs. We talk about the importance of implementation fidelity, the value of community-based research, and her favorite 80s movie. All of that and more on this episode of the Prevention Matters podcast.
The National Prevention Science Coalition is the premier professional association dedicated to translating scientific knowledge into effective and sustainable programs and policies to enhance the well-being of children, families, and communities. To find out more about the National Prevention Science Coalition or to become a member, please visit www.npscoalition.org. And now the host of the Prevention Matters podcast, Dr. Robert LaChausse.
Cady Berkel is an associate professor in the College of Health Solutions at Arizona State University. Dr. Berkel focuses on reducing health disparities, including substance use, mental health, HIV and other STIs, and obesity through research on the dissemination and implementation of evidence-based programs. She received her bachelor's degree from the George Washington University and a doctorate from the University of Georgia. Welcome to the Prevention Matters podcast, Cady.
Thanks so much. It's great to be here.
So I want to first ask you about your background and your experience in prevention. How did you get into the field?
Well, I was so fortunate. I joined the University of Georgia and specifically Dr. Velma McBride Murray's lab right before the Strong African American Families program was going into the field. So I really got an experience and training that I think few prevention researchers get to have. That's one of the few evidence-based programs designed especially for African-American families and really tackles some of the, issues related to health disparities head on by focusing on things like discrimination, like how do you talk to your kids about discrimination and racism and those things? How do you prepare them for that future and help them be, resilient and thrive?
And so when you were sent off to college, did you think that you would be where you are today?
Well, I really had no idea. I think when I first went to college, I was really interested in issues related to, first psychology, but also kind of justice issues and legal issues. I thought for a while about being a forensic psychologist. But actually, as I studied at George Washington, I got a major in psychology and a minor in criminal justice, and really just learned a lot about the disproportionate consequences of, certain behaviors and activities, and how that they have really led to just the tremendous disparities in our justice system. And so at that point, I started to rethink my career choices a little bit. Then I volunteered for a while at a center in DC that supported, women who were having kind of stressful pregnancy experiences. And I got to see, I got to know some of the social workers who supported them, and just really like watching the amount of burnout that happens for those social workers who are kind of internalizing all the stress and having to bring it fresh every day with every new case and situation. I was like, well, there's probably a way to prevent all this. Like, couldn't we intervene earlier? And so, reduce the kind of stress and suffering of the moms, the babies, the social workers that supported them, and really everyone. So that's kind of what led me down the pathway to prevention.
So when did you come across specific work in prevention science, like Joe Durlak's work and folks like him? Was that in graduate school?
Yeah, let's see. I got into that piece. So I guess that really stemmed from when I was involved with the Strong African American Families program. One of my responsibilities as a graduate student was to code all the tapes for Fidelity. So it was a really interesting experience because the conceptualization of Fidelity has changed a little bit over the years. And at that point in time, it was kind of like, you know, you wanted to basically make, you know, these efficacy trials of preventive interventions kind of similar to like pharmacotherapy kind of a trial. So, and if you're thinking about the program as, you know, it's like the intervention is kind of similar to the drug that you're testing, and you want everybody to have the same like dosage and you know, content of the pill. So I remember actually having a conversation about, okay, we want everyone to have the you know, the same pill essentially. And as I watched those sessions over the years, it was really just very illuminating to me how you know, there was so much more to it than that. So for example, we had, you know, some program facilitators that really didn't, you know, want to follow the model at all. And would actually even, so we had like this kind of video that would play throughout that had like vignettes and a little bit of talking head kind of stuff, but also had like a timer because we knew that like, if we just let the conversation go, it would go all over the place. So there was a kind of a timed discussion period. And, you know, a couple of the facilitators would just turn it off. They're like, we're just going to talk about what we want to talk about and focus on that. And those sessions were like the most highly attended sessions. So even though they were necessarily covering the content exactly as it was written, you know, the family loved it. And then, you know, there were other situations where it was kind of like, there was just a lot of kind of creativity with how the program was delivered. And in some cases I felt like, you know, and they were all, we hired all of the program facilitators from, you know, similar communities to the ones we were working in, with the expectation that, you know, the kind of cultural match would support the delivery. And in fact, it did, because they would change things sometimes that in ways that made them, I think, maybe a better fit even than we had attended. So that was kind of where I got on the path of like, there's so much more to it than just like, did you check every box on this, you know, kind of manual, and started looking at things like, you know, the implementation quality. So like kind of the rapport building and how clearly did they convey the information, as well as, you know, the participants' responsiveness, which is something that really, I think, gets neglected in a lot of D&I work. It's, dissemination implementation research hasn't really highlighted the experience of the participants, I feel like, in the way that it should. Right. So that's where I really got into Durlak and Dupree and started like thinking about all those different components and how do we measure those and how do we, you know, create, you know, like theories out of these, you know, many taxonomies are out there. And to really understand what's going on in these sessions and how we can make them a better experience for families and more effective. Right. And so this whole idea of implementation fidelity, right, or program fidelity, is something that people, you know, I've seen in the literature have been talking about for, you know, 20 years. Yeah. But when you look at a lot of effectiveness trials, looking at, you know, program evaluations, hardly anybody's collecting data on implementation fidelity. So can you tell us what implementation fidelity is and why it matters? Yeah, so one really tricky thing is that everybody's using different terms to mean different things, or different terms to mean the same thing, or the same terms to mean different things. So when I say fidelity, I'm kind of talking about like, did they go point by point and do everything they were supposed to do? And then I use quality to kind of talk about, the skills with which they delivered the program. But sometimes people lump those into one thing, one overarching thing called fidelity. So I think, we're really all still kind of coming to agreement on our use of terms. But it's really challenging to measure. It's very time consuming. It's expensive. When you're looking at these large scale trials, which we need to do to be able to really understand like how to support the implementation of evidence-based prevention in, routine settings. So when I had a grant to look at the implementation of the New Beginnings program within the context of an effectiveness trial, we actually got like a second R01 just to look at the implementation. So that makes it really challenging. Most people don't have the luxury of getting multiple funding mechanisms, just to look at the implementation. So, we really need to develop, there's been talk for a long time too about, kind of efficient, but also valid measures of implementation. The literature seems pretty, set that like just asking facilitators or program providers if they did, if they implemented with fidelity, they say yes.
Right.
And then there's not a whole lot of validity to that. But on the other hand, if we're thinking about, sustainable models because we don't want to just measure fidelity in within the context of effectiveness trials. We know that it's important going forward. So we need to figure out ways that we can measure it in community settings when it's measured, when programs are delivered ongoing. So, so it's a really tricky thing. There's some kind of innovations. One thing that's really cool, I've been working with a couple folks who are using machine learning, computational linguistics strategies to kind of automate the coding of implementation of multiple domains, so quality, fidelity, responsiveness. And I think that has a strong potential. There's always, challenges associated with like, you need to get the recordings of the sessions and all of that. But that's definitely one potential mechanism that we might be able to do it. Also, kind of thinking about like participant report of some of the components could be effective. But yeah. I think, the reason that it's just not being measured or being measured well enough is a resource constraint issue. Yeah.
And I've done some work examining implementation fidelity, particularly looking at teen pregnancy prevention. And we published a study a couple of years ago where we were looking at a school-based teen pregnancy prevention program. And we were operationally defining implementation fidelity, kind of like, dose and reach, participant responsiveness, attendance, session quality, looking at adaptations and adherence, and looking at why facilitators made adaptations or adherence. And when I talk to folks at conferences and even when my graduate students, we address this idea of implementation fidelity. And one of the things that I used to say was, hey, we need to implement these programs with as much fidelity as we can. We need to train the facilitators and, we need to get it cookie cutter. And one of the things, right? And one of the things that I've learned is that no program is implemented with 100% fidelity, And I had a student a couple of years ago ask me, well, what % of all of these implementation fidelity factors do you think you'd need to have in order to make sure the program had the effect, that you wanted? So let's say a reduction in unprotected sexual intercourse or something like that. And I was like, I don't know. Right. I don't know. I'd like to be able to say, 80%, right? But I don't know. So the question I'd have for you is, in terms of like primary prevention programs, so like, obesity prevention programs with youth or, HIV prevention or even alcohol, tobacco, and other drug prevention, what do you think are the most important implementation fidelity factors? Is it adaptation? Is it adherence? Is it dose? Is it reach? Is it session quality?
Well, this is going to be probably a really boring answer, but it depends. I think, one of the biggest challenges is that, we have these kind of theories about how our programs work, but we have not tested those theories. So we can't say for sure, what matters the most. So until we have that information, we really don't know. Like, it's just conjecture. I think, there are a lot of things going on. So, a lot of the prevention programs we see declines in parent depression. Why is that? Even when it is not targeted. We also have lots of like spillover effects in the prevention world that we were not expecting. That's kind of how I went down the obesity path with one of the programs I was working on. We found like effects on obesity. So it was like, oh, well, let's pursue that and see where that goes. I really, kind of believe in the whole person approach, but yeah, so like maybe it's, things like, is it delivered via group or, via like an individual intervention? Like maybe that makes a difference for, the effects of the program. So that, that's a key piece of fidelity, but if it is like the nature of like being in a group-based intervention, then it depends on like who's in the room with you and if they're kind of, positively oriented towards improvement, then that's the factor that matters. So I think we really need to do a better job of like kind of understanding like why our programs work and who they work for, and then we could really say, what pieces of implementation are most important. So I know that was kind of a non-answer, but okay, let me say one thing though, is that in the research that I have been doing, it seems like, there are kind of mediational pathways going on between, the program facilitators' delivery of it, and then the, from a, family-based program, their engagement with it. And it's not like what's happening, really during those sessions. It's what's happening at home, between the sessions in everyday life. So it's the parent's ability to, take the material, engage with it, and actually put it into practice that's really driving the effect. So I've done analyses looking at, parents' use of the home practice skills, and that, fully mediates the effects of like quality and fidelity on improvements in the targeted outcomes. So if you had to, if you wanted to like pin me down and you had to pick one thing to measure, I would say, participant responsiveness, and especially like use of the program skills, in terms of what was and then of course, like then working backwards to, the fidelity and the quality, they're both important for making sure that, people are coming to sessions and that they're doing the skills correctly and all of that kind of thing. But yeah, based on what I looked at, I'd have to say responsiveness.
So the question I get most often in my world of doing substance use prevention and teen pregnancy prevention is, you've got this program and it's demonstrated effectiveness, in a randomized control trial that was conducted by, university-based researchers. Yeah. And it had been conducted in a public school setting or even in a hospital setting. And then people want to take that particular program and they say, okay, now we want to implement it with a different population, or we want to reduce the number of sessions from, let's say, 12 sessions, 12 one-hour sessions to 8 sessions. What is your feeling about how practitioners can best think about adaptation versus adherence?
Yeah. I really wish that more community research partnerships were happening, because I think that's really what we need. Because, as I was referring to earlier, we don't really know necessarily the primary mechanisms and, who things will work for it, who they want. And there's kind of this like red light, green light approach that some programs use to say like this adaptation, might be good, but this, this other one might be bad and detrimental to program outcomes. I think without like really understanding the theory behind the programs and how they apply to different populations, that's a really tricky thing to be able to make those determinations. So I would love to see the field move into the direction of researchers really partnering with communities, because researchers really need to know more about, kind of what the context is. A lot of our programs have gotten, it's kind of a good and a bad situation where, now we have decades of evidence supporting the programs, but that also means that the programs are like decades old and somewhat dated. And some of the things that come up, might not be relevant anymore, or there might be new things that need to be considered that, the program doesn't include. So we really need both, communities to learn from researchers about the theories behind the program and the core components and things like that. But we need researchers, prevention scientists, to be embedded in the communities to understand like what are the issues that are going on now and what are the implications of that for, program redesign.
Yeah, I think that's a good point. And that leads me to my next question, which is, how do we reduce the research to prevention practice gap? So, you've talked about the fact that we have, 10, 20 years of some pretty good information about what works in preventing drug use, or, parenting programs, or even early childhood intervention programs. But oftentimes what we see happening in the real world doesn't reflect that evidence-based. So how can we as researchers reduce that prevention practice gap?
Yeah, I would say, really it's the partnerships and the like mutual learning, because, our history is that we were designing things just to see if it would work, in like 20, 30 years ago, we didn't even know if this would work. So it was just kind of well, let's give it a shot. But now that we know, that there's some signal there, we really should be starting with, both the people who would benefit from, a program, folks, experiencing health disparities, those kind of things, and the context in which the program is going to be delivered, and really putting those things first and not developing programs that, will sit on a shelf for 30 years. That doesn't fit anyone. So it's really that kind of mutual exposure and partnership to reduce that. It's just critical. We will not be able to reduce that gap unless we start doing more research community partnerships.
Okay, let's move into our lightning round. I'm going to ask you some questions. First thing that pops into your mind, just go ahead and respond. Are you ready?
Okay.
What sport were you good at in high school?
Sailing.
What is your favorite movie from the 1980s?
The Princess Bride.
As you wish. What is your favorite Girl Scout cookie?
Tagalongs.
What is one thing your parents don't know that you did when you were a teenager?
I plead the fifth.
There's gotta be something.
Nothing that I could talk about online. They might watch this.
Right. Or your students might hear this.
Yeah.
Even worse. Okay. What's the most number of hours you've watched TV in a single day?
Ooh. I used to really enjoy watching trilogies, beginning to end. So Star Wars or Indiana Jones. So that must be about, would you say 6 hours or 7 hours, something like that?
What is a chore that needs to be done at your house right now, but you don't want to do it?
I have a puppy who continually destroys everything in the backyard. So right now, I think he has destroyed the fake logs in our little gas fire, and I need to go clean those up.
What does a person need to be happy?
Oh, friends and family.
Well, Dr. Berkel, thank you for spending your time with us on the Prevention Matters podcast. I really appreciate you being here.
Thanks for having me. It was a great time.
The Prevention Matters podcast is the official podcast of the National Prevention Science Coalition. To find out more about the National Prevention Science Coalition or to become a member, please visit www.npscoalition.org. If you'd like to hear more episodes, please click on the subscribe button.